Good morning, everybody. So, we had already dealt with axis and also the basics of ECG. Today, we are going to see about normal ECG measurements, what a beginner should know before calling an ECG is normal. So, we are going to go through the same things as I told you before: rate, rhythm, intervals, QRS, axis, uncorrected QTC. So as you can see, first check the calibration. So calibration is very important. So the paper speed should be 25 millimeter per second and the voltage is 10 millimeter per millivolt. So this is the calibration that is there. So you should see this calibration. It will be available in all the ECGs. And as I already told you, ECG measures the electricity from the heart and it is recorded in a graph paper. The x-axis measures the time and the y-axis measures the amplitude. So each small square is around 0.04 seconds or 40 milliseconds, and each big square is point 2 seconds or 200 milliseconds, and five of these, 1, 2, 3, 4, 5 of these will cause 1 second. So you remember this is for time, and as well as for voltage, you know how much is each small 1 into 1 millimeter block represents 40 millisecond time and zero point 0.1 millivolt amplitude. So one box represent zero point 0.2 millisecond, that is 200 millisecond time and zero point 0.5 millivolt. And our reference is 1 millivolt and 10 high. So this is very important. You always look for this in your ECG. When you have taken an ECG, you have to see exactly this standardization is there. And rate and sinus rhythm. So normal measurements start with a normal rhythm. Adult resting heart rate is between 60 to 100 beats per minute. Rate alone never defines normal. Some athletes and sleep and some medication and during illness, heart rate varies. Athletes sleep and medication, heart rate can go down a little bit, and illness as fever is there, then the heart rate will rise. So, but usually resting adult heart rate is between 60 to 100. When do you say sinus rhythm? There is a P before every QRS, and every QRS is after a after every P. That is QRS is followed by a P. Then P is upright in lead 2 as well as negative in AVR. Decide for beginners, decide regular or irregular before calculating the rate because it's important. It's whether it looks regular or comes regular, you can take a strip of paper and you can see whether RR is regular or not. That's also a very useful thing to do. So next you are going to measure the P wave. You have seen the calibration, then you've seen rate and sinus, then you see the P wave, and then a P wave should be which represents the atrial depolarization, and QRS, that is the P wave, should be less than 120 millisecond or less than three small boxes. Amplitude best checked in lead 2 should be less than 2.5 millimeters. Normal direction of P is positive in lead 2, negative in AVR, and as well as often biphasic in V1. That alone is not abnormal. It represents P wave represents the atrial depolarization with height and what is the direction. You need to see the direction. All these three things you need to see. Then coming to PR interval, how much it starts from the P wave until the start of the QRS complex. So you start from the P wave until the start of the QRS complex. This is the PR interval. So PR interval is usually 120 to 200 millisecond, 3 to 5 small boxes. Less than 120, it's short PR interval. More than 200, it is a prolonged PR. Measure the PR where the P wave onset and QRS onset is clearly visible. So it's very important to measure the PR interval. Next, go for the QRS duration. How long does ventricular depolarization take? So this is more important. So you typically normal is between 70 to 110 millisecond. That is 2 to 3 small boxes. Prolonged means you are looking at a conduction defect. So usually it will be only 2 or 3 small boxes, only 2 or 3 small boxes. So if it is more than that, then we are dealing with a prolonged conduction. Conduction delay is there. So anything more than 120 millisecond, then it is a bundle branch block with the morphological criteria. So a QRS of 3 small boxes or more is definitely white. This axis is very easy to understand. So I've gone axis is just you to tell see lead 1 and AVF. If both are positive, it is normal axis. If lead 1 is positive and AVF is negative, then you're dealing with a leftward axis. And if lead AVF is positive, it is a rightward axis. And if both are negative, it is an extreme. Axis is not a diagnosis, always correlate with the rest of the ECG. So important to think about it. Then there is QTC. It changes with heart rate. So we use corrected QTC. So what is the corrected QTC? You can use the Bassett's correction and then you can calculate the QTC. So usually QTC is less for males, 450, and females it is 460 millisecond. Borderline needs context and manual verification is important. More than 480 is corrected QTC is a major diagnostic threshold in European guidelines as long QT guideline. Do not diagnose from a single automated value. If the automated value is more, always manually calculate the corrected QTC and determine it. Anything more than 480 or 50 milliseconds, it's grossly abnormal and we need to see exactly what. This is also important. That is Q waves and R wave progression. These are morphology checks, not just numbers. So normal septal Q wave, small Q can be seen in one AVL and V5, V6. Think pathological only when it is deep and there is and it is deep and wide and there is two leads. Say V1, V2 has it or lead 2, lead 3 has it. Then we can consider it as abnormal. Small tiny T waves is fine. It's fine. Normal septal Q waves are fine, but there are abnormal when there are clearly deep and wide present in anatomical contiguous liquids. Use context rather than a rigid single cutoff. Context means see the patient, whether the patient had old MI, patient has chest pain or not. So that is more. So then you are looking at the R wave progression. So R wave progression, usually R is generally becomes first initially you have a small R wave and a deep S wave. Then as it goes on, the R becomes smaller, R becomes bigger, and the S becomes smaller. And V5, V6, the transition occurs. V3 and V4, the transition occurs. Then V5, V6, it becomes a completely full R and a very small S. So this is important. This transition zone is usually around V3 and V4. V5, V6, it's completely transition. So poor RV progression can be technical, positional, old infarction, LVH conduction. Never interpret it alone. So poor RV progression is there. You need to see the context of what the patient has and then interpret it, whether it is normal or abnormal. So this is the normal ECG checklist. Check calibration. You need to check it needs to be there in all the ECGs. Then check the rate. Context matters again. Then check the sinus rhythm, P wave, PR interval, QRS, axis you need to check, -30 to +90, important. In QTC, screen for prolongation, verify manually. If there is a prolongation is there, verify manually. Morphology, no concerning Q waves, reasonable R progression, no STT abnormalities. Then the final question you need to ask is there anything does not fit the patient? If there's ECG change, but the patient is normal, or the ECG is normal and the patient is totally abnormal, you need to see exactly does the ECG fit the patient or not. So it's important to do. So for all practical purposes, any ECG handed, a patient coming with chest pain, you do ECG, please go through step by step and make your diagnosis. Thank you very much. Have a great day.